video and try to review these rationales, that you'll be able to do that.
Oh, what you did last time, that was very nice. Thank you.
You're welcome. So you see, you have these things, and when you look at this, I want you to look at things that are particularly in bold print. Okay. But for every condition or everything that you get asked about, you should be able to know like 5 or 6 things about it. All right. And those things are actually listed right up here. But the main thing with these drugs are you got to watch patients that smoke, and you also have to be concerned about the blood clots. So smoking actually increases that risk for the blood clots. So if you saw a patient that had smoking and they had some sort of heart disease, and they, you know, have a history of DVTs, you're definitely not going to want to give them something like this, right? Because it's going to mess with them. And as you see, it says right on there, hormonal contraceptive. So generally the hormones that we're talking about here are estrogen and progesterone. All right. I got to remember what program am I in so I know where I got to go to switch the screen. Okay, who's reading?
The graduate nurse is, I can see, is caring for a laboring client with, I can't see, guys. Epidural
anesthesia.
Yeah, okay. So
you want us to read? I can read. I'll read for you. The graduate nurse is caring for a laboring client with epidural anesthesia. After the client pushes for 3 hours during the second stage of labor, the healthcare provider decides to use forceps to assist the client to deliver secondary to maternal exhaustion. Okay, so mom's super tired now. So now the doc's going to help, and he's getting these forceps out. Which action by the graduate nurse would require you to intervene? So what are you not going to do here? Or what are you going to do? Let's talk about that. What's one thing that you're going to do for sure?
So would you from the pressure?
Train the client.
This, I don't know.
Okay, so 2 you have to do.
Okay.
So if the nurse didn't do that, I would intervene. 3, I would believe that you would have to do, just for legal purposes, because in a forceps use for delivery, injuries can happen, and it could result in lawsuits. So you probably would want to do that.
So why would you join that the bladder? What is the rationale?
Well, what happens when the bladder gets full?
Okay.
What happens?
Put pressure.
It's gonna expand, right? Because
Yes.
it's kind of like a balloon. So when it's empty, it's kind of flat, but as it gets urine in it, it expands, and sometimes it can even deviate a little bit to one direction or the other. Now you're introducing forceps, and you're putting a sharp tool in there, so it could cause a laceration to the bladder or nick it or cause damage. So you want to drain the bladder before we try to go ahead and deliver this baby using any sort of tools.
Okay. So
I'm pretty sure that's going to be the rationale for 2.
Under pressure. Puppet. So 104.
Which one sounds like it could cause a problem?
1.
Okay. Go with your common sense Judge Judy factor then, okay?
What do you think, Hermes?
Do you agree with that, Hermes?
To apply fundal pressure, I don't know. This one got me. I'm looking at it like clueless.
Okay, well, let's see.
I'm looking at for. Okay. Just guessing.
So let's see the rationale for that. I use the vacuum. Exhaustion. Okay.
Miss Sue, could you explain the rationale? Because I can't see this.
Okay.
Sorry.
So if you push down while the traction is being applied, you could cause the uterus to rupture.
Okay.
So you never apply fundal pressure during an operative vaginal birth. Okay.
Mm-hmm.
Number 2 was exactly what I said, so that we don't damage the bladder. You want to make sure that you catheterize the patient before you use forceps. Number 3 was exactly what I said. For legal purposes, you want to make sure everything is documented. Okay. And number 4, you're going to notify the physician when contractions are palpated, so that traction downward and outward can be applied to the actual forceps. So the physician, you'll be palpating for the contractions while the physician applies the forceps, and then you'll say, mom's having a contraction, and at that time, the physician is going to apply pressure to the forceps or to the vacuum, because normally in a birth, mom would push during the contraction, right? Since mom can't push because she's too exhausted, you're going to palpate the contraction,
okay.
notify the doc, and then he'll use the vacuum or the forceps in place or to assist mom's pushing during the contraction to help extract the baby.
Okay. Makes sense.
Thank you.
You're welcome.
The graduate nurse is reinforcing teaching for a client who is initiating contraception with the etonostrel and etinoestradiol, whatever, vaginal ring, with statement by the graduate nurse required the nurse preceptor to intervene. Number 1 said hormone from the ring are absorbed in the bloodstream to the vaginal mucosa. If the ring is accidentally removed, rinse and place it back in the vagina within 3 hours. The vaginal ring is effective as soon as you insert it in. Wear the vaginal ring for 3 weeks, then remove it for 1 week. So, which statement will require the preceptor to intervene?
So I'll say 1 is correct.
I would say 4. The vaginal ring is effective. What would it be effective as soon as you put it for 3 weeks, then we move it for 1 week? Why?
rinse and yeah. Yep. So 1 and 3 is correct.
Okay.
I think.
But I'm looking at 4.
You like 4 or you don't like it?
I don't like that. Right. I like 4 as the answer. That's the one that will cause.
I think 4 is wrong.
Yeah.
Yeah.
Then remove it. Yeah, like you can't remove it.
I think 4 is right.
Oh, really?
They put it for 3 weeks and remove it.
Mm-hmm.
Okay, so hold on. So it's the ring is.
I'm looking at 2 then. 2.
Rinse and put it back.
If the ring is accidentally removed, rinse it and place it back within 3 hours. Why not right away?
Huh?
Number 2. Why do we have to wait?
Accidentally moved, rinse it and put it back within the vagina for 3 hours?
Yeah.
Could be a possible answer.
Yeah, I'm thinking, okay, why 3 hours? Okay, I'll go with 2 for now.
No, I think 4 is the wrong answer. I mean, it's the right answer.
Where the back vagina? But we're looking for the bad one, though. Why?
Yeah.
Okay.
I mean, okay, so wear it for 3 weeks and then remove it for a week.
Let's see what the 4 says.
Okay. What?
So, the client should insert and leave the ring in place for 3 weeks.
So if the hormones are going into your bloodstream, it probably requires time, huh?
Okay. Mm-hmm.
And number 4 is actually true. It stays in for 3 weeks and then it comes out for a week. Okay. And then it goes back in. Because otherwise the person probably won't have a period because of the hormones.
Okay, wow.
Yeah.
The nurse performing an initial newborn assessment observe a bluish discoloration of the hand and feet. The trunk has a pink color. Which action by the nurse is appropriate? Place the newborn skin to skin with the mother.
That's your answer?
That's for me. I don't know about Lovetta.
Okay.
Because newborn, the bluish discoloration is okay.
Pink. Okay.
Okay.
Yeah, I'll say so.
Okay, so tell me why you would do 4 and what it's called.
The cyanosis, something like that. How do you say it? Which they said that.
Okay. Tell me what this skin to skin is called.
Skin to skin is the bonding.
What is it?
It's not the bonding time for
No, it's not the bonding.
It's skin to skin.
No, place the newborn skin to skin with the mother.
I think there's.
So we call that kangarooing.
Yeah.
Kangarooing, okay? And we put the baby next to the mom to warm the baby up. It's the best way, one of the quickest ways to warm the baby up, as long as the baby has a pink trunk, okay? It's acrocyanosis is what it's called. And as long as the baby has that pink trunk, okay, it should warm up and the color should come around, you know, fairly soon. Okay, good.
So that's 4? Okay.
Yeah. I was close, but not
That's
quite.
a normal finding.
Normal, yep.
Okay, good.
Okay. A client of 20-week gestations report running up to the bathroom all the time, pain with urination and foul smell in urine. Which question is most important for the nurse to ask when assessing the client? Okay. Have you had a urinary infection?
Have you found?
Okay, she's going back and forth to the bathroom.
Have you
The urine already smell, foul smell in urine. Any pain?
Are you having any pain in your back?
Do you like to have you found that urine movement?
Do you back?
Okay, what urinary tract infection?
So this question.
Okay, I would say number 1.
Okay.
Because Lupetta, you have something that you wanna add? You have a different answer.
So foul smelling urine, that's bacteria infection.
Okay.
Yeah, and pain, she is 20 weeks gestation. Pain accompanied with that fouler smell, and especially in the lower back, it's not a good sign. That's my logic behind my number 1. And if you had
one, it's going to tell you more about the condition that the patient's having. 2 is going to tell you about the possible cause, which really isn't going to help with the issue.
No, not at all.
Okay. 3 might be true, but it's not the frequent urination that's an issue here. She has pain and foul smelling urine. And 4, we might want to know about, but it's going to tell us about history as opposed to what's happening right now.
Yeah, so.
All right, so 1, I guess.
So we're gonna go with 1 and see.
Good.
Okay.
Yep.
Okay, so you're looking at your clinical findings and you're trying to make a, diagnosis here, nursing diagnosis. What's going on with the patient? You're trying to make these judgments, these calls, okay? And you have to bring these inferences and these cues together in order for it to get you to the right answer. And, you brought a nice, interesting point to it, Miss Hermesis, by saying that, you wouldn't expect this patient at 20 weeks to have these other issues.
Yeah.
And again, you could talk about the toileting hygiene, but that doesn't help assess what's currently going on. Assessing for the history of the UTI isn't going to address her current issue. Okay, good.
nurse is providing education about the vitamin K injection to the parent of a newborn client. Which statement by the nurse is appropriate? So in this one, we're looking for a good one, vitamin, okay. After the first week of life, vitamin K deficiency poses no risk to the newborn. If your prenatal diet was high in vitamin K, the vitamin K injection provides little benefit to the newborn. No. Vitamin K deficiency is known to cause growth delays in newborn. Wow.
No.
Could be. Vitamin K is essential for preventing bleeding, which can occur spontaneously or after procedures such as circumcision.
That one. 4.
Yep.
Okay, good. All right, so the levels are low in the newborn.
Yeah.
And that's why we have to give it right away. All right. And that's going to help promote that blood coagulation. As you see right here, all these things here, you got these things in bold. Okay, you got about 4 things right there that you want to know about vitamin K. So vitamin K will be important to you too when you talk about Coumadin, right?
Yes.
Because it's an antidote for Coumadin. So that's why we ask people about green leafy vegetables. It's not that they can't have them when they're on Coumadin. They can have them, but we want to know that they're eating the same amount every week, because if they increase or decrease the amount, then it's going to change how much Coumadin we have to give them, because it's going to change their coagulation factors.
A nurse is caring for a pregnant client at 27 weeks gestation. After a motor vehicle collision with a side airbag deployment, the client's blood type O negative. Which laboratory test should the nurse anticipate it? That should be easy. Indirect comb test.
Okay, good. You're looking to see mom's blood mixed with the baby's, right?
Yes.
Good job. Okay, so anytime there's a potential for mom's blood to mix with the baby, we got to check this out, because we might have to give Rogam, right?
Yes.
All right, we really want to give that Rogam before that happens. So that's why when someone's having a amniocentesis or they get a certain stage in labor, we go ahead and give it.
A client at 39 weeks gestation with preeclampsia has a blood pressure of 170 over 100, 2+ proteinuria, and moderate peripheral edema. Immediately after hospital admission, she develops seizure and uterine contraction. Magnesium sulfate is prescribed, which finding indicate that the drugs achieve the desired therapeutic effect. So blood pressure is less than 130 over 80. The seizure activity stop. Urine has 1+ protein. Uterine contraction stop. So what do we want to accomplish now if we give the magnesium sulfate?
Well, why are we giving it?
We give magnesium sulfate to stop the uterine contraction.
In this case, we're giving it for
the seizure?
To prevent seizures.
Yeah.
Okay, so number 2 is the correct answer. To stop the seizure. Okay. Control seizure.
Why is it not the blood pressure to bring down the blood pressure?
Because it's the seizures that we need to control. But magnesium, the way magnesium works anyway, okay, if we have too much magnesium in our body, it sedates us and it brings our pressure down naturally. If we have not enough magnesium in our body, then it's going to bring our pressure up.
Okay.
So once we give it, we have to monitor the patient now for, and you'll see questions on it. We have to monitor them for magnesium toxicity, okay? We have to make sure the kidneys are working.
Oh, okay.
The high blood pressure is a sign of the preeclampsia. That's
Okay.
being caused by the I guess by the magnesium levels being too low.
Mm-hmm.
Okay. In her case, for this patient, she is like 39 weeks gestation. She is close to delivery. But let's say that she wasn't. Let's say she wasn't, and would it be like number 4 where they administer the turbulent, magnesium sulfate, and indomethacin to stop the contraction and to check if the lung has mature?
Yes.
Oh,
so
okay.
In a much earlier stage, like maybe before 23 weeks.
Oh, it's right there. I didn't even see that yet. Okay. Yeah. It's still in the data.
Because after 23 weeks, you know, that's what we have to think about.
Okay, so she's...
All right, at what stage can we deliver? Because you really can't deliver a viable baby until after 23 weeks.
Okay. The nurse is performing an Apgar score assessment on a newborn client at 1 minute of life. The newborn completely blue, has a heart rate of 110 minutes, and is emitting a weak cry. Active movement and flexion of extremity are noted, and the newborn grimace when near a suctions. Which Apgar score should the nurse assign this newborn? So the normal is 10, right?
So the normal is 10.
The normal is 10. The baby has a weak cry. Okay, completely blue, has a heart rate 110. The heart rate is low.
So completely blue would be 0?
Completely blue is okay.
Oh.
No,
Okay.
no, some part.
Blue is not okay.
It's not okay. Some part can be blue, like the hands and the...
So would that be a 1 or
Well, blue, completely blue would be 0, according to my scale.
Yeah.
If the hands and feet were blue, but the body was pink, then it would be a 1. And if the baby was completely pink, then it would be a 2. Okay.
Okay, so for the color, he didn't get no points. 110 is low, right?
Okay, 110 is probably going to be a 2 because the baby could be like 110 to 160.
Yes, it's 2. And weak cry
would be a 1?
It could be a 1 or 2.
It would probably be a 1.
Yeah.
1. So that's 2 points total.
And the other one said okay.
Active movement and flexion of extremity are noted.
I'll say 2.
Yeah.
Thank you for that.
And grimace when near a suction. So
that's 2, right?
Yeah. So it would be like a 6.
It might be a 6. I'm thinking that the reflex might be a 1, but let's see. Okay, 6, good.
Okay.
I didn't like the way the grimace was on mine. Mine says grimace, cough, sneeze, but.
Miss Sue, can I take a picture of that square
Yeah,
thing?
yeah.
Okay, thank you.
Mm-hmm.
Okay, thank you.
Mm-hmm.
Completely blurs 0. Okay.
So
Yeah.
1.4.
So UWorld says, you know, greater than 100, you get 2 points. Some books say greater than 110.
Okay, 5 minutes.
So I would look, you know, in my author and see, because if they test you on this,
I think the book, does the book say 120?
Yeah, the book might have it too.
You might want to look at your chart in the book, okay? Because if they test you on the APGAR score, they might test you by your chart in the book.
Mm-hmm.
So I just want you to, you know, not all charts are equal. But they're going to test you according to your author. So that's why I'm saying just pay attention to the one in your book to see if it matches this.
What is it, Mace? Is it 120 to 160?
Which one?
The heart rate.
110.
In your
110?
book?
Yeah,
in our book?
160. Eh?
In our book, it's 110?
Yeah.
Oh, okay.
So not 110, yeah. The nurse is observing a student nurse care for her mother who has been unsuccessfully with breastfeeding her newborn infant. Which action by the student will require the nurse to intervene? Assess the baby position and sucking behavior during the breastfeeding. Demonstrate to the mother how to use an electric breast pump. Provide supplemental formula feeding until improved breastfeeding occur. Show the mother how to hand and express breast milk. Okay. Demonstrate the mother how to
Assess the baby
breast milk.
second, yes.
What would you provide supplemental formula feeding? Number 3 sound a bit bizarre to me. Provide supplemental formula feedings until improved breastfeeding occur.
Why does it seem odd?
Provide, let me read it again. Provide supplemental formula feeding until improved breastfeeding occur.
Tell me why it seems odd.
I can't think why, but I'm just looking at it and like,
Come on, you know why. Tell me why.
So what if... Okay, go ahead.
Go ahead, Levita.
No, I was gonna say, what if the mom has like breast infection? Like, will she still be able to like breastfeed?
No.
Well, this isn't about a breast infection, really. This is more about, it's probably a young mom who really doesn't know how to breastfeed. And so, you know, we have to teach them how to latch with the baby, how to bond with the baby, how that baby has to be held and all that stuff. It's not something that some new mom just naturally grasp. So as a nurse, you're teaching these moms how to do this.
Okay. Yeah, maybe I'm just reading into the question.
Things would be wrong if you were teaching mom. What would be wrong to teach her or to mention to her? So
I think 1, 2, and 4 are right.
Okay, so tell me why 3 is wrong. because in order for you to understand the concept, you have to understand why it's wrong. And that's just all I'm asking you, is to tell me why it's wrong.
What would
because 3.
What would she want to provide supplemental formula?
Okay, thank you. If mom is breastfeeding, you're not going to recommend supplemental formula.
Yeah,
it goes against her grain. Okay, so that's why it's wrong. All right. If mom asked you, can I supplement my breastfeeding with the formula, then you could bring about the facts. Hey, yeah, you could. It's not as beneficial as breastfeeding. They really recommend that you stick with breastfeeding. But if mom felt like the baby wasn't getting enough food, then you could introduce it. But you don't introduce it to mom until she introduces it to you, really, unless the baby is nutritionally suffering. If the baby's at risk, then that's a different story. Then we might have to bring something like that up.
Yeah.
So we don't want to use anything that would interfere with mom's ability to exclusively breastfeed. Okay, that was the rationale. That's all I wanted to know. So a lot of times when I ask you why, I want to know why, because I want to know that you know. So when you get this another way, proposed to you a different way, you're able to still answer that question. It's just picking at your brain. See how well that brain's working.
Client at 34 weeks gestation report constipation. The client has been taking 325 milligram ferrous sulfate TID for anemia since the last appointment for 4 weeks ago. Which recommendation should the nurse make for this client? So select all that apply. So what we're gonna tell her? We're gonna tell her to
fruits and
increase
vegetables.
fruits and vegetables.
Okay.
We're gonna
Exercise.
tell her to do moderate, and that's it.
That's it. Final answer. No coffee in the morning.
Hold on. No coffee in the morning.
No coffee.
Dang it.
Decrease. Yep. No coffee.
Okay, good. All right, look, there's your 5 or 6 things in bold for you. Okay.
Moderation to pregnancy. Yep. The obstetric nurse is reviewing phone messages. Which client should the nurse call first? Client at 18 weeks gestation taking cetrazone and reporting mild diarrhea.
Okay, so that's Rosefin. It's an antibiotic, ceftriaxone.
Yes. A client at 22 weeks gestation with twins who is taking acetaminophen twice a day. It can be for headaches or for fever. It's a NSAID.
Okay. A
client at 20 weeks gestation taking metronidazole and reporting dark color urine. That's an antibiotic also.
Okay, it's an antifungal actually, and is dark colored urine an expected side effect of that medication?
Okay.
Is it? Is it? That's
yes.
Right. Is it?
Oh, yeah.
Side effect? Okay. Just like is diarrhea an expected side effect of triaxone? Okay, good.
Yes.
Yeah.
A client at 30 weeks gestation taking ibuprofen for moderate back pain. So which one she gonna call first? Which one we're looking for an emergency? I think the 30-week gestation taking ibuprofen back pain telling me something at 32 weeks gestation. I don't know. Lovetta, what do you think?
Mm.
So are you picking it just because you think none of the other choices are correct?
I'm not saying they are correct, but they said the answer said which client should the nurse call first? Priority.
Okay, so did you know, I know the reason why you picked it is because of the back pain. And you're feeling like at 32 weeks that the back pain could be contractions or something else?
Yes.
Okay. Are you familiar with some of the ways that they use ibuprofen? Did you know that they use ibuprofen sometimes to close the ductus arteriosus in premature babies or babies that have problems closing it?
No, I wasn't aware of that.
We have to be careful in clients that have heart conditions and clients that have kidney disease with this because it can cause toxicity because they can't excrete all the products out of it. So it does have anti-inflammatory product qualities, but NSAIDs have something to do with prostaglandins and inhibition of that. So you could be onto something with the 32 weeks, and that would be why, because it could cause problems with the unborn baby. So at a certain time period, I think around 30 weeks, our clients really, we don't want them to take ibuprofen in large quantities.
Okay.
Let's see if it's the right answer.
So they're giving us the classification. The fetal is.
Must be recording.
Oh, it said right up exactly what I said, huh?
Yes, that's why you are a teacher. We avoided in the third trimester due to risk of premature closure of the fetal ductus. Yeah.
So why is number 4 wrong?
Because number 4 is an NSAID. Okay. And like I said, these NSAIDs, they are these prostaglandin, what did I say? Prostaglandin inhibitors. Anyway, they inhibit the prostaglandin synthesis, okay? And part of the use for these, they use these in premature babies. They found that when they give high doses of this in babies that have problems with closing the ductus arteriosus, that this can help to close it. That's part of the quality of it. So after 30 weeks, about 30 weeks gestation, you don't want your clients taking ibuprofen on a routine basis because it can cause harm to the baby. So up until about 30 weeks, it's safe to take moderate amounts of ibuprofen. But after 30 weeks, it can start to cause harm to the unborn baby by doing things like it might close that ductus arteriosus before the baby's actually born. And that's part of changing over from intrauterine life to extrauterine life, right? Is that closure that shunts that blood. So if it closes too early, things are going to happen to the baby that aren't meant to happen yet.
Got it.
Okay.
So the ductus arteriosus could close early. All right. And you wouldn't want that to happen.
I was thinking about the uterine contraction, all this. But that's good though. We were able to talk about that. I didn't know that part of it.
So I actually have a set of triplets in my family that were given high doses of the NSAIDs. Two out of the 3 survived, and they were treated this way with the NSAIDs to close their ductus arteriosus after they were born.
Wow.
Oh, wow, cool.
Now, you think things really can't happen in life sometimes when you see them in a book, but I also just lost a good friend last week. She had an epidural during her pregnancy. She just gave birth to a baby boy about a month ago. She has 4 boys, including the one she just had. And she went home and she developed a blood clot where the epidural was.
Oh, man.
Oh, my God.
She ended up going back to the hospital. They had to do a surgical procedure on her. I don't know what happened during the procedure, but she went into DIC. They tried, and she ended up with an infection, and they tried to give her like blood, and they tried to give her heparin. They tried to reset like the DIC. They usually give, heparin to reset it. And they tried blood transfusions and nothing worked. And she ended up dying like 3 days ago from this blood clot from. So it's crazy that this stuff can really, it's really exist, that it can really happen, all from an epidural.
Hmm.
The labor and delivery nurse is receiving report for a pregnant client who is having a scheduled cesarean birth for a placenta accreta. Which information is priority for the nurse to ascertain? The client has a history of 3 previous cesarean birth. The client has assigned consent from a cesarean hysterectomy. The client has removed all metal jewelry and contact lenses. The client has 2 18-gauge IV in a blood type and cross match. So we're looking at
a priority measure. So in order for you to know the priority measure, you have to know what would be the severe complication of this. So what happens when the baby's born in this condition?
So in the placenta accreta is what was it again? When the placenta when it kind of detach,
and when it actually doesn't detach.
Oh,
okay. In placenta accreta, the placenta sticks like glue to the inside of you. Okay, and as a result, you're bleeding through. Okay, in placenta accreta, the placenta sticks like glue to the inside of you, and as a result, you're bleeding through. What happens when you're bleeding? You're going to go into what? Shock, right?
Shock, yes.
Okay, it's a severe condition, and it can cause severe blood loss once the baby's born.
So that's when they have to do the Wogan?
Well, this isn't about Rogame, because Rogame is about what?
I'm looking at number 4, where it said...
well, number 4 you would want to do if your patient was going to have severe blood loss, because if you had to do a blood transfusion, then all this needs to be ready to go.
Okay, so the client has a...
So we don't just do this when someone's on Rogame. We do this anytime we're going to infuse blood.
Okay, the client has assigned consent for... So what is which information is a priority? So so what is okay, number 1.
Well, you were onto something with number 4. So why'd you change it back to 1?
I thought you said it wasn't good. That's why.
No, I said in 4, because you mentioned Rogame for number 4. And I said, we're not just doing number 4 for Rogame. If our patient needed a blood transfusion, we would have to do number 4 also, right?
Yes.
Is this patient at risk for a blood transfusion?
Yes.
Yeah.
Okay. Thank you. So I think 4 is probably your answer. I don't know for certain, but I would go with it.
See, that's what happened when we go back and change our mind and do this. When you rationalize too much, not sure.
But if you know the disease process, you know the complications, then you know what you have to do, nurse.
Okay.
You can't know what to do if you don't know the full complications of the disease and what's happening with the process. So the fact that the major issue with complication with this is a life-threatening hemorrhage, you have to be prepared to give that blood. So I wasn't trying to take you away from the answer. I wanted you to understand that because you mentioned the ROGAM, and I think you mentioned that because it talks about blood type and cross-match.
Yes.
Okay, and I wanted you to understand that we always blood type and cross-match when we're giving blood, not just when we're giving ROGAM.
The nurse is performing telephone triage with a client at 30 weeks gestations who think she may be in labor. Which question will help the nurse determine whether the client is in labor? Select all that apply. Okay, if the contractions are getting stronger, yes. Because if it's false, it can, if they start working, stop.
Okay.
Does anything you do make the pain better? So if she does something else to make the pain better, that could be a forced labor. Have you lost?
So do you want that or no?
No.
Okay.
Have you lost your mucus plug? How frequent are the contractions? Number 4. And what do you feel it? What do you feel the contraction pain most? Lovetta, if you want to add, you can. I'm just, or if you want to change anything. I'm not sure about the mucus plug. Have you lost your mucus plug?
Which question? So 3 is part of the answers? I don't know. I'm not sure.
So you're thinking you might want 3?
Yeah.
All right. Well, I mean, if you're wrong, you'd be wrong now, right? Instead of on the exam.
Mm-hmm.
Okay, so it wasn't 3, but it was 2.
Was 2.
Amateur labor, true versus false. Now that's a box you might want to take a picture of because that should change. I'm sorry, did you get it?
Yeah. Yeah.
Okay. You can use your mucus plug several days before labor. It's not necessarily a sign of labor. A lot of times people will lose it, but they don't actually go into labor. And then, so they're just gonna, you know, check you out, make sure you're not at any risk or whatever. And
so,
go ahead.
The nurse is caring for a client who reports severe abdominal pain and vaginal spotting. The client has a positive urine pregnancy test at home, and her last menstrual period was 8 weeks ago. Which client report to the nurse is most concerning? So abdominal pain at 8 out of 10, history of pelvic inflammatory disease, intermittent nausea and vomiting for the past 7 days, right shoulder pain and dizziness. So, right shoulder pain, dizziness. 8 out of 10. Abdominal pain, that's pretty high. So history can be a concern, but it's history.
Well, I want you to recognize what's going on right now.
Yes, abdominal pain rates at 8 out of 10.
What's going on with the patient right now?
We can eliminate number 2 and number 3 from the get-go.
Okay.
I'm looking into abdominal pain rated at 8 out of 10. Right shoulder pain and dizziness.
Okay, what's the right shoulder pain and the dizziness? What's that?
Could be.
Isn't that oh my gosh, I just forgot.
Let's see what right shoulder pain and dizziness means.
That's
So 3 sounds like morning sickness, so we're getting rid of that, right?
Yeah.
A pelvic inflammatory disease. Abdominal pain rated 8 out of 10, but we're talking about most concerning. So the right shoulder pain and dizziness goes with ectopic pregnancy.
Yeah, that's what
and then, you know, we're going to see probably some hemorrhaging.
Oh, yeah, that could be the.
Yeah, I remember you said that. I remember you said that, Hermes, like the last time we were doing this. Yeah.
Ectopic pregnancy.
Yeah.
Yeah. Yeah, having a kid come with a lot of problems. How many do you have, Mitsu?
How many kids do I have? I had 2 naturally, and I'll never have another one naturally. Period. I'll adopt who I have anymore. I raised 22 foster kids. But I only had 2 of my own because after the second one, I had them tie my tubes after I had an argument with the doc. She didn't tell me I wasn't old enough to know that I needed my tubes tied. Okay, so now I want to switch over to some pediatric questions. All right.
Hermes, do you want to do Pete's questions or do you want to do more maternity questions? Because I'm I mean, I don't want to say I'm okay with peds, but like I need help more with maternity.
Okay,
I mean,
let's stick to it. We can stick to it. I'm good.
That's up. I mean, that's up to you
for
too.
me, it doesn't matter because me, I need help in both, so it doesn't matter to me. So
okay, we can do both. That's fine.
Give you like another hour here or there with the pediatric questions if you need me to.
Okay.
Yeah, it doesn't matter to me.
Okay. All right. So, you know, this is going to give you very valuable information about pregnancy. So I really like to use this program with you guys with it. I just feel like it gives you so much information.
Yeah, pregnant client at 30-week gestation come to the prenatal clinic. Which vaccine may administer safely at this visit? I know influenza can.
For the DTaP.
Yeah, the 4.
Mm-hmm.
Not the varicella.
No.
Okay, which ones are live?
Influenza, you can give influenza.
5 is live.
I can give both influenzas?
Not the nasal spray. I don't know about the nasal.
Okay, so you cannot give the nasal spray because it's a live virus.
Yeah, 1, influenza injection.
Okay. And that should be your final answer, right?
Yes.
So, okay. So when can you give MMR?
I believe you have to give MMR like a couple of months before somebody gets pregnant or after they have the baby.
Okay.
You can't give it while they're pregnant. And if you give it after they have the baby, then I think they have to wait like 2 or 3 months before they become pregnant.
Okay.
This actually says 4 weeks. All right. So they have to wait a month once they receive a live virus before they can become pregnant.
So they said it right here a little bit. The MMR vaccine and varicella.
Yeah.
They have live viruses in them.
Okay.
And
remember that when this is done, I'm going to have a recording for you and I send you that YouTube. So you'll be able to go back and read through these.
Okay, good.
Thank you. The nurse is preparing a nutritional teaching plan for a client planning to become pregnant. Which food will best prevent nutrotube defect?
Neurotube defects. So what kind of food are you looking for?
We're looking for, is it organ meat?
Folic?
I think I saw that somewhere.
Not organ meat.
Wild salmon? I don't know. It's either wild salmon.
You're looking for foods with what in it? Tell me what you're looking for foods. What do you want them to have in it?
Folic acid?
Folic acid.
Folic acid. Okay. Well, I want to say it's fortified cereals, but I might be wrong on that.
Yeah, I'm thinking that
wild
too.
Salmon? You think it's wild salmon?
I think it's 2.
Let's just try 2.
Brussels sprouts, chicken peas, liver.
Okay, your salmon is those omega-3 fatty acids.
So the salmon was the right answer?
No, the right answer was the fortified grain products, the fortified cereals.
Oh, okay.
And green leafy vegetables has a lot of it too.
Yeah, if they put the green leafy vegetables in there, this is how they get you.
You have to know nutrition, nurse, for every aspect of nursing. Now you're learning that, right?
Yeah.
Yeah.
You gotta have it for every aspect. It doesn't matter which one you're talking about.
A client indicate the desire to become pregnant. Which of the following are important preconception education topic for the nurse to provide? So, avoid alcohol and
so aim for BMI.
Okay.
40, I think. I don't know.
Okay.
I think all of them look good.
Good job.
Good job, Hermes.
Oh, not here. It's good too. It's practice, but on the exam.
Yeah.
Nurse is evaluating the fetal monitoring strip of a laboring preemie gravida at 30 weeks gestation who is receiving an oxytocin infusion and has external fetal monitors and intrauterine pressure catheter in place. Which of the following interventions should the nurse implement? So we gotta click the exhibition thing to see the thing. So the top one is the fetal heart rate, the bottom is uterine contraction, right?
Yes.
Right. So what's the question?
So if we're looking at right here, from here to here is deceleration.
So the question is asking, hold on a second. The question is saying you're evaluating the strip of a prima gravida at 38 weeks gestation in labor. She's currently receiving oxytocin. She has the external fetal monitor applied and an intrauterine pressure catheter in place. What intervention should you implement based on the fetal heart rate?
Okay.
Now we want to see the fetal heart rate.
So is that late deceleration?
So
variable deceleration.
According to the fetal heart rate, I think there's a problem in the fetal heart rate. Deceleration is mostly deceleration. And right here is not doing anything at all. So the fetal heart rate is at 150 going down, 120, 110, 100. I was okay. If you finish seeing head, the Lovetta?
Yeah.
I will administer supplemental oxygen.
Yes.
I will stop the oxytocin.
5.
And I will reposition the.
No, not supine. No, not supine. Sideline.
Not the supine.
Okay.
Okay, amniofusion. What is amniofusion again?
I think that's when we give amniotic fluid because it's too low.
Oh no. IV bolus of
IV bolus. Normal saline.
Okay, what's the rationale?
So can we? Okay, so if we're giving like IV.
So
normal
yeah,
saline,
well,
right?
if there's not enough amniotic fluid, then we might give it if we felt like the variable decelerations were, I guess, associated.
Okay.
It may, giving the amnio infusion may decrease or eliminate problems with a reduction or absence of amniotic fluid or with variable decelerations during labor. So I don't know if it's indicating that might be what the issue is.
Yeah. I'll say 1 and 5. I don't know. What do you, Mace?
But I'm looking at I still don't know what is the rationale behind the bolus normal saline IV?
I'm not sure that we would do that. Yeah, I don't know what the rationale would be for that. Because there's not a blood pressure issue. It's not.
Yeah,
we're lowering
fluids.
Okay, 1, 3, and 5.
And 3? You think it's 3? Okay.
Well,
2.
Answer. So let's see why.
Yes.
Well, I didn't know why, but we'll find out. But number 3.
Well, I knew it wasn't 3.
If you suspect that there's not enough amniotic fluid.
Okay, let's see why the IV though, because we were limbo between the yeah.
Okay. What is the rationale for 2? Because
let's see.
Step, sideline position, apply oxygen. Oh, administer IV bolus as needed.
Must be for circulation.
And administer IV fluid. But it doesn't say like why though.
Yeah.
Well, let me see if I can figure out. Let's see. For late decelerations. Okay, so let's see. I'm thinking because it might help with some sort of infusion, maybe the placenta infusion. All right, we're gonna go on to the next question while I'm researching.
Yeah, let's give us something for our mind to think about while you're doing this. The nurse is assessing a 4-day-old term neonate who is breastfed exclusively. Which assessment finding should the nurse report to the healthcare provider for further assessment regarding possible formula supplementation?
Wait.
Okay.
I'm sorry, Miss. Could you read the question again? I'm so sorry. I can't see.
The nurse is assessing a 4-day-old term neonate who is breastfed exclusively. Which assessment finding should the nurse report to the healthcare provider for further assessment regarding possible formula supplementation?
Okay, so we're looking for the wrong answer? Okay.
So 10% weight loss since birth, that's normal, right?
That's normal, yeah.
Crack, peeling skin, Feed every 2-3 hours. That's okay too.
That's normal, yeah.
Runny, seedy, yellow stool. What is runny?
Is it a diarrhea?
Watery or liquidy.
Yeah.
Oh, that's normal.
No, I mean, 4 days old, the stool, seedy. If it's breastfeed, they said they look seedy. I don't know about the runny. I know runny is diarrhea, but the seedy yellow stool for a breastfeed baby, it's okay.
But it says breastfeed.
Yeah.
It says, right?
So it's asking about why they might regard possible formula supplementation. So what did I tell you about formula? That the baby is exclusively breastfed. When is the main time we would offer formula? What did I say?
If they're not gaining weight, there's a problem?
Exactly.
Okay.
So 10% weight loss since birth.
So really your baby shouldn't have lost 10%. About 5, 6, 7%. 10% is a lot.
So that's mean the feeding is not okay.
Well, the baby might not be getting enough from the breastfeeding, so we may have to supplement it. Maybe it's having weight loss for some other reason. We don't know yet until we evaluate, right?
Yes. So Lovetta, the CD stool is okay, the breastfeeding. If you go back to the
No. I knew that though.
Oh, okay.
Yeah. I was saying it was
all
right.
Baby poop is wet. New baby poop is wet, runny, liquidy. Okay, now let's talk about the bolus of saline. Okay, so it was exactly what I said, the placenta insufficiency. So because the mom's getting analgesia, it could make her hypotensive.
Okay.
All right, so if she gets hypotensive, what's going to happen is the placenta is not going to feed as much as it should, because it's going to pull from, just like it does in shock, right? When we're hypotensive, the body pulls from those dominant organs, and it pulls to the heart and the lungs, which are the major organs. Those ones have to get blood if nobody else does. So we get that bolus hoping that it's going to go ahead and cure that hypotension, and eventually it will help bring fluids and help that placenta perfuse better. And so hopefully that helps with those late decelerations. So for late decelerations, okay, in that case, the main goal is to replenish that uteral blood flow, that uteroplacental blood flow, which we did by correcting the hypotension. Okay, and we do that with that bolus of normal saline, because that's generally why we give that, is when someone needs that blood level raised because it's hypotonic, so it stays where we put it, right? Also to increase the fetal oxygen, which we're going to do by putting mom on her left side and giving that oxygen by the face mask. All right, and then we're also going to discontinue the oxytocin. All right, so all those things together are going to help correct what's going on with the baby.
A laboring client at 30-week gestation come to the labor and delivery unit with preterm rupture of membrane about 18 hours ago. The client group B streptococcus status is unknown. What intervention is a priority for this client? So we're looking for what we would do. Administration of bullshit.
So
30-week gestation.
So how do you test for B-step, whatever it's called?
Well, I'm guessing that you would do a clean catch.
Yeah, so I was thinking too. 3.
If she ruptured her membranes, I don't think we're going to do a vaginal exam.
But
we're not going to give prophylactic antibiotics.
No.
Determine what she has to give the correct antibiotics.
I'm thinking 3.
Labor, so we might have to assess how far along she is first, though.
Okay.
I'm thinking. And then do that clean catch, but I don't know. I'm thinking though, she 18 hours ago.
You pick your answer already?
Yeah, I'll say 3.
What you think, Hormesis?
Okay, we can pick 3. I don't know.
Still thinking it might be 2.
Let's see. I will go with
Oh, it's 1. How about that?
maybe okay, maybe present as a part of colonization. It can be transmitted to the newborn. So
because she tested positive for the group B, they're going to go ahead and give the prophylactic antibiotics.
okay.
What was the answer?
That was 1. Give the antibiotic.
Yeah, they didn't test her yet, but they're saying if the status is unknown and the membranes have been ruptured that long,
okay.
temperature is greater than 100.4, which it doesn't talk about the temperature here, so. So I guess it's a priority is to go ahead and prevent, because you do know that the client's at high risk for this group B, so I guess to go ahead and prevent the infection. All right, well, I can add that to my chart of learning tonight. I just went for the nursing process for assessment. That's where I was headed. Okay.
Okay, so the pediatric nurse is performing an assessment on a 4-week-old client in the clinic. During the assessment, the newborn mother, she start to cry and said, "I am the worst mother in the world. What should the nurse ask next? Do you have a support system to help process your feelings? Do you have any question about how to care for your newborn? Have you experienced difficulty falling asleep or getting rest? Have you felt depressed or hopeless over the last 2 weeks? I think number 4.
Okay.
Mm-hmm. Yeah, I think so too.
Good.
Yeah, postpartum depression disorder by client. Yep.
Okay, good.
A client at 41-week gestation is admitted to the labor and delivery unit for labor induction. The nurse is assisting the healthcare provider in a amyotomy. What action should the nurse anticipate? Select all that apply. So assessing the fetal heart rate before and after the procedure is a good thing. Amyotomy. Yes, you every 2 hours you check the temperature. I know you check the temperature, but I don't know about the frequency if it's every 2 hours. Do you know anything about that, Lovetta?
No.
Okay. Informing the client if she feel a sharp pain during the procedure. Supine position. Okay, so far I'm looking at 5. Okay, you would okay, the supine. I know after amyotomy you wanna
every 2
why
hours.
supine though? Supine is in
No, it's not supine.
after. Okay, informing the client that she will feel a sharp pain during the procedure. Yeah, what action would the nursing assistant, the healthcare provider? She will feel a sharp pain during the procedure. Amyotomy, sharp pain. Keeping check the client temperature. I know they check the temperature, but every 2 hours, how often?
Maybe every 30 minutes. I don't think it will be every 2 hours though.
So what about the
Or
position?
maybe like every hour.
They take the fluid from the umbilical cord. Amyotomy. They have to be in a supine position in order to do that. Right? After the no, not after the procedure. Not after.
Supine position after. No.
Checking the client temperature. Okay, I don't know. I will go with 1, 3, and 5. What do you think, Lovetta?
1, 3, and 5. Informing the client that she will finish. So why would she feel a sharp pain?
Sometimes it's from the hook or whatever that they use to do.
Oh, okay. Yeah. Okay, that makes sense.
Final. Oh, what happened?
Whoa.
Time is expired.
No, that was something else. I just hit the wrong button.
Oh, it said assessing the fetal heart rate. Yeah, checking the temperature every 2 hours and noting the characteristic of the amniotic fluid. So every 2 hours was fine.
So it actually, there actually is documentation that they'll feel right-sided pain or discomfort.
Okay.
I'm not sure why they don't have it on here, but
making bigger water is okay. It's painless.
the
Supine
breathing of the anatomy itself is painless, but
doing upright position.
Yes, upright position after the procedure. Okay.
So at least every 2 hours, Loverda. So
Okay.
okay, now we colorless with clear, colorless, and without any foul odor. Okay, if it's yellowish, green, if fetal has meconium in utero. So strong odor, foul odor, indicate infection.
all right, if it's greenish, then that it's meconium.
Yeah.
I guess they call it discomfort or or pressure, okay, that some people may feel. Some other pages, you'll see it listed as actual, a little bit of right-sided pain.
Okay.
All right, but for, I guess, for testing purposes, they may not even ask you about it again. You might not even see it again. You might just see the other things.
The nurse is caring for a 1-day-old client at term gestation who is irritable, feeding poorly, and only sleeping for very short intervals. The newborn mother informed the nurse that she has been taking hydrocodone on a regular basis for several years, which intervention is appropriate to include in the newborn plan of care. So
what's going on with the baby?
the mother was on trial. The baby is irritable, not eating properly, and doesn't sleep, should sleep for a little period of time.
So what's going on with the baby?
The baby has good
Neonatal abstinence syndrome is what we call it.
Okay.
Okay. And so how do we treat that? What things don't we do?
Okay, so
what does that mean? The baby has neonatal abstinence syndrome. What does that mean? So baby's withdrawing from the hydrocodone that the mom's been on. It's addicted to the hydrocodone, okay, and it's withdrawing.
okay, so it's like it's going out of the system. It's like taking the taking, I don't know if I'm saying it right, taking methadone to, is it the same effect or it just?
Well, the baby's withdrawing because it's exposed to the hydrocodone that the mom's been taking. The hydrocodone is in the baby's system, and now the baby is born, and the baby's not getting the hydrocodone. So it's withdrawing from it. So how are you going to care for those babies? What kind of things do you want to do for a child that has neonatal abstinence syndrome or that is withdrawing from narcotics? How would you care for them? What kind of environment do they need?
They need stimulate with the light regularly.
No, definitely not.
Calm.
Not
we'll do 4.
Yeah, you're going to do 4.
Okay. 4.
You're going to put them in a calm, quiet area. You're definitely not going to stimulate.
Okay.
Swaddle and gently rock the baby.
Swaddle. Gently.
So if you work in pediatrics, you'll actually be evaluating babies for this. You can kind of tell when they have it. You can also tell with the moms too. You sometimes not away a lot of times right away with them because the mom's going to be getting narcotics after she has the baby for a few days. So depending on how much she takes, on how noticeable it'll be with her.
Okay, a nurse is admitting a client at 42 weeks gestation to the labor and delivery unit for induction of labor. What is a predictor of successful induction?
Hmm. 10.
Okay, good.
Bishop score 10.
Yeah. All right, let me take a picture of this box.
Firm, medium, soft, position posterior, anterior, 62. Okay.
So if the Bishop score is less than 6, what does that mean?
That the mom is not ready for labor.
Okay.
Or induction thereof, I should say. In other words, if we're going to induce, we're going to give something to induce labor, we would want her to have a favorable score, which is greater than 6.
Okay.
All right.
So 6.5?
Huh?
6.5 or 7?
Well, according to this, anything for someone who's never had a baby, anything greater than 6 to 8 if you're inducing.
Okay.
So I guess it depends on also whether or not you've had babies before.
Right.
The nurse is participating in an obstetrical emergency simulation in which a client is hemorrhaging after a birth due to uterine inversion. When describing interventions, which statement by the nurse indicates a need for further education?
Number 4.
So a need for further education. You're not going to do number 4?
Not.
Oh yeah, I will do number 4.
Mm-hmm.
I don't.
I will do number 4. A need for further education. Okay.
So. What would she notify? And avoiding staff of the client condition immediately.
I think it may be the oxytocin, but that's just a guess on my part. But
I will administer a rapid infusion of oxytocin before the uterus is corrected.
So what is the inverted uterus?
It kind of flips the opposite way of what it's supposed to be. And it's usually accompanied by like hemorrhaging and shock.
Okay, so, yeah.
Life-threatening emergency.
Oh, yeah.
So I won't give the IV.
If I'm wrong, then you're right. Then that's good, okay? Because you know more than me today.
Oh, you're right.
Okay, so it collapses, caves in, or flips in, and then you have a sudden hemorrhage and shock. All right,
yeah.
So
A gravid client in early labor and is admitted and report intense back pain with contraction. The fetal position is determined to be right occiput posterior. Which action by the nurse will be most helpful for alleviating the client back pain during early labor? Okay, applying counter pressure to the client's sacrum during contraction, encouraging the client to remain in bed during early labor, positioning the client on the left side with pillow for support, requesting that the nurse anesthetist administer epidural anesthesia. This is what we're gonna do. I will do number 3.
I would do number 1. Oh.
Okay, pick one, Miss Sue.
What would you pick, Miss Sue? Okay.
I'm not sure that the positioning is going to help because of where the baby's lying.
Okay, you do. Let's see the rationale. Why not position it?
Well, you could be right, Miss.
No, we can see because at least that's our trial and error here.
Yeah.
Right.
Yeah.
Okay, so you were correct.
Yeah, so one is correct. Lovetta is correct. That's the ROP.
Yeah.
ROP. So it's going to increase and slow the labor, increase pain and slow the labor. That's one of the problems with it.
Okay.
And you apply the pressure with a closed fist. You want to encourage position changing every 30 to 60 minutes.
The precepting nurse is supervising a new obstetric nurse performing a labor admission assessment on a client's suspected spontaneous rupture of membrane, which action by the nurse will cause the precepting nurse to intervene. Okay, documenting the positive nitrogen test result when the test strip turned blue. Donning non-sterile glove and using soluble gel for vaginal examination. Palpating the client abdomen before applying external fetal monitors.
Oops.
And went away again. Providing the client with a variety of clear liquid to drink. So the membrane rupture.
What's the highest risk? What's the highest risk? When the membrane rupture? The patient.
Infection?
Okay, infection.
Non-sterile glove and using soluble gel for vaginal.
I'll say 2.
Infection, right? What would prevent the infection?
What did you say, Mr.?
If our highest risk is infection, what would prevent it? Because we have to intervene. We have to stop this nurse from doing something that she's doing, right?
Yes.
So we're going to stop her from putting those non-sterile gloves and doing that vaginal exam, right?
Yeah.
Okay. Uh, 37 weeks pregnant women come to the emergency department with a fracture of ankle. Which assessment finding is most concerning and require the nurse to follow up? Fetal heart rate remain 206 per minute. Fetal kicks 4 times in the past hour. Mother reports feeling 2 contractions every hour. The mother's hemoglobin is 11.
Is it 1?
So 1 is terrible.
Yep.
Yeah.
Okay.
This one is so heavy. It's 206. That's
yeah.
A client at 30-week gestation is brought to the emergency department after a motor vehicle crash. She reports severe, continuous abdominal pain. The nurse note frequent uterine contraction and mild, dark vaginal bleeding. What action should the nurse take? Select all that apply. Okay, so number 2. You will do 4 and
5.
We can do 5.
IV answers of
What do you do? Okay, report severe continuous abdominal pain. So I think you just should prepare her for emergent cesarean.
38 weeks, yeah.
Yeah.
Okay.
I don't know about the number 3.
No, 5 is wrong.
So we'll do emergency cesarean.
You want to look at the answers again?
You will continuous external monitoring, and you will do a blood, okay, for cross matching.
So I think the reason why the 22 gauge is wrong is because I feel like if you're giving blood, it has to be a little bit bigger.
Oh, okay.
Yeah, we said it earlier. In
really? So, like, how much?
Like a 16 or an 18.
16 or 18 gauge. Okay.
Okay.
So look at your antepartum bleeding things first. You know, those are the different ones: placenta previa, uterine rupture, placenta rupture. And now you're looking at your placenta abruptia, what happens, and what you have to be prepared for.
A nurse is caring for a client who had a vaginal birth 2 hours ago. She delivered a baby 2 hours ago. The client has a saturated perineal pad in 20 minutes. During assessment, the nurse noticed that the client has a bulgy fundus that deviated to the right and slightly above the umbilicus. Which intervention should the nurse perform first?
Ew. So empty the bladder.
Yeah.
So we're doing 1?
Yeah.
So you want to do this before you massage?
Yeah, because, well, with this, there's indications, okay, because the fundus is deviated to the right.
Okay.
It's giving you that clue that the bladder is the cause here.
Okay.
So the bladder distension could prevent the uterus from contracting efficiently. So that's why you have to correct that first, and then you'll do your fundal massage.
Nice.
Okay, guys, I got to shut it down for tonight, but what I was thinking is maybe on Saturday we could do like an hour. My class is going to probably be ending between 2:30 and 3 o'clock, so maybe we could do like an hour of the peds then. And then on Sunday nights, if this time works for you, we can do the maternity.
Yeah.
Okay.
I mean, Hermes
Okay.
does up.
Thank you very much, Miss Sue. We really
Okay.
appreciate you doing this on a Sunday for us.
Yeah, thank you so much.
You're welcome. And when this video converts, I don't know if it'll be tonight before I get back to it, but I'll get it out to you guys on a link.
Okay, thank you so much. Have a
Okay.
good night.
And I have a question about my grade.
Okay, did you get your grade already?
I mean, yeah, I did get my grade.